Hi guys, welcome back to my channel. Today I want to discuss about placenta previa, placenta equita spectrum, diagnosis and management, Fogsi guidelines. Okay, first I'll tell about placenta previa, then placenta equita spectrum. So placenta previa, we already know. This is placenta previa. So placenta previa is low-lying placenta. So you'll have uh, life-threatening complications of placenta previa and placenta equita spectrum disorders. So placenta previa is in the lower uterine segment and is great upon the distance between the lower edge of the placenta from the internal os. Okay, so placenta equita is the trophoblastic invasion is abnormal. So it is an equita, inquita and perquita. So even in the absence of ultrasound binding, if the clinical risk factors are present, then you can diagnose the equator spectrum disorders. Okay, you can screen placenta previa. Ultrasound is very strong. You can go for MRA if which can complement ultrasound findings. What are the risk factors? Obviously, any surgeries, so previous cesarean, myomectomies, any hysteroscopic adhesiolysis, TCREs, curatages. Okay, previous placenta previa, any ART conception, multiple pregnancy, increase in the age, smoking and drugs. These are risk factors. So placenta previa, previous cesarean section, previous placenta previa, ART myomectomies, gynecolysis, curatages, TCRs, multiple pregnancy, increased age, smoking and drugs. Okay, so every patient should have a screening for placenta previa at uh, uh, 18 to 22 weeks. Okay. Less than 18 weeks, we should not diagnose with this placenta previa. So, what is the new classification of placenta previa? Whether it is low lying or placenta previa, which is covering the internal os, then it is placenta previa. And if it is low lying, it is the less than 20 mm from the internal os, then it is low lying. Okay. TVS actually reclassifies. If you see in ultra abdomen, if you do TVS, it reclassifies almost 25 to 60% of the placentas. Okay, and 90% of the patients have the placenta migrating to the fundus. If the placenta is thought to be low lying or previa, then TVS is recommended 32 weeks. Okay, then yeah, this is important. So how to diagnose placenta? See, you diagnose placenta previa, low lying placenta previa. So you'll do 32 weeks. If it is persistent and there is no symptoms, and again you'll call and do at 36 weeks. Okay. So if placenta previa low lying, there is no surgeries, then you do transfusion ultrasound at 32 weeks. If placenta previa and low lying, if there is previous cesarean section, then again you do ultrasound and refer her to specialist center. Basically, the difference is refer her to specialist center. Okay. So first I'll tell about asymptomatic. If she's asymptomatic, then do cesarean 36 to 37 weeks. If she's asymptomatic low lying, then repeat ultrasound at 36 weeks. And you'll prefer, it depends upon the obstetrician. If you want to do normal delivery also, you can go for normal vaginal delivery in low lying. If she's asymptomatic in low lying placenta previa or recurrent bleeding episodes, then give steroids and plan for cesarean section at 34 to 36 weeks. 36 weeks basically. So in placenta previa, you go for antenatal care, pre-operative care, post-operative care, intraoperative care. Okay. So first antenatal care. So if there is recurrent, if a lady came with placenta previa and she's having bleeding, spotting, so recurrent bleedings are there. So what you'll do? You'll ask her to come regular antenatal care, hospitalization when needed. Make the hemoglobin level. Okay, you should give more than 11. Okay, you should see the source and circumstances. What is the distance from the home and hospital? What is the transportation facility? What is the bleeding episodes? How many bleeding episodes? What is the lab results? You should ask her to maintain the blood products donation of blood and all. Okay, if she's asymptomatic, then you say, see, you can have preterm delivery, you can have hemorrhage. You should counsel her. There is no rule of circulars. You should prevent anemia. If there is any history of bleeding in RH negative, you'll give anti-D. Okay. Within 3 weeks, if she's bleeding, then within 3 weeks, if she's bleeding, there is no need of repeating. After 3 weeks, you will repeat based on KB test. If there is no KB test, then give again 300, no problem. Okay. Delivery, if there is uncontrolled bleeding or FHR is abnormal or if the mother is unstable, then delivery. That's about antenatal care. Pre-operative, now we are delivering. Now you want to deliver her cesarean section. What you'll do? First, you'll counsel her what is the high risk. We'll ask her there is a risk of blood transfusion, indications of blood transfusion. If she says that doesn't want blood transfusion, document that. Then you can ask her there is a random cell salvage method. If she doesn't want any other blood transfusion, you can give her blood also. Cell salvage, and you should keep 14 to 16 gauge IV Canada. Regional anesthesia can be given. Spinal anesthesia also you can do delivery of placenta previa. Interruptive care. You should localize the placenta and clamping the umbilical cord immediately. Placenta is transferred due to fetal delivery, and control to control hemorrhage. You should keep all the pharmacological drugs. Now, what are the surgical techniques to stop bleeding? First thing, what are the bed? If the bed is bleeding, the oversew that blood, oversew that bed area, placental bed. Then, if it is bleeding is not controlled, then uterine artery ligation, ovarian artery ligation, intra-iliac artery ligation. Okay, you can go for compression sutures, intrauterine tampon, and finally you can resort to hysterectomy. If there is interventional radiologist available, you can call them urgently. That's about intraoperative. Coming to postpartum, after delivery, when she come to the ward, na, you go and debrief her. See, in your operation, in your surgery, these are things happen and all. You should give thromboprophylaxis, okay, heparin and all. You then also you'd be continuously vigilant on the bleeding. And other operating team and the post-operative team. See, operating team and post-operative team should know that what is happening with the patient. Okay, critical care services should be available whenever required. That's about placenta previa. Now coming to placenta creta spectrum disorder. So I already told there is a trophoblastic abnormality, invasion abnormality. So there is placenta accreta, increta, percreta. Okay, every patient who have that serious like positive risk factors, they should be screened. Okay, risk population should be analyzed. Okay, so first thing is level one thing is ultrasound evaluation, and you should evaluate the clinical risk factors. Okay, if there is previous history of cesarean section and a lowering placenta previa, then you should screen for PASS. No single or combined ultrasound sign is specific for depth of abdominal presentation. Depth of thickness of composition of blood depth should be assessed. Okay, high degree of suspicion, then you should refer her also. You can refer her for good ultrasound. Second trimester, see, first trimester in 11 to 14 weeks also you can find out some features. First thing, there is low lying placenta on the previous low lying GSAC at the previous cesarean scar. Then there is irregularity. There is irregularity in the placenta and myometrial interface. There will be generally the clear space between the placenta. That clear space will be lost, and the thickness of the myometrium is also less than 1 mm. Okay, due to color Doppler, there is dilated veins, dilated vessels, and there is periplacental vascularity. Bladder wall will be interrupted. Okay, in second and third time it's also same. You should take the history like cesarean section, placenta previa, uterine surgeries, age of 35, smoking, myomectomy, curatages, multiparty Ashermans. So if there is scar pregnancy and you are asking them to continue the scar pregnancy, there is 100% chance of placenta ectata spectrum, 100% chance. Okay. Then other parameters should be taken. There is some one blood test like alpha fetoprotein if it is raised, then is increased risk of placenta previa. Okay. Same thing. Ultrasound features in second trimester the same thing. There is myometrial thinning, placental bulge on the serosa, bladder wall interface is lost. Focally, you can see that coming through the serosa, multiple vascular lacunae, placenta myometrium, reduced retroplacental thickness, extension of the placental myometrium. These are things. Color Doppler, there is hypervascularity, turbulent flow, increased vascularity, vessels bridging the placenta to the uterine margin. MRA may complement the ultrasound findings, depth of invasion, lateral extension of myometrial invasion, bladder invasion. MRA is non-mandatory, not a mandatory one because sensitivity is only 94%. Okay. What's the role of MRA in diagnosis? Like it is very difficult to find on ultrasound, like posterior placenta or depth of invasion can be found out in MRA. So follow-up should be present in second and third trimester as well. How to manage the placenta creta spectrum? So multidisciplinary unit should be present. Antenatally, the hemoglobin should be 11 gram. Obstetrician anesthesia, urologist, neonatologist, and interventional radiologist should be present. Sometimes you can call cancer surgeon also. Okay. Preoperatively, these people should be present, and you will ask her and ask for surgery at 35, 36 weeks, and you educate her about preterm delivery and hemorrhage. Okay, consent should be taken. High risk consent should be taken. What the risk? Hemorrhage, lower urinary tract damage, blood transfusion risk, and risk of hysterectomy. If she doesn't want any blood transfusion, in case of massive hemorrhage, you say cell salvage can be given. Interventional radiologist will come. Okay, you should tell that. Antibiotic prophylaxis should be given. Then course of steroid as this is elective surgery, so you'll give steroids 1 week before only. Regional anesthesia, general anesthesia, anything can be done. Yeah, triple P procedure is very important. 3 P's are there. A very important question. They used to ask me even in DSGO. They asked me in this Viva question. Okay, important question. So first thing is perioperatively you will localize the upper placental edge. Second is pelvic demarcation. Third is placental non-separation with myometal excision followed by myometal defect. Okay, so I already told in our hospital what they'll do now, on the abdomen, we'll do a placental mapping. With the colored pen, we'll map where is the placenta. That is what perioperatively localize the upper placental edge. Okay. Second thing is you separate all the vessels, peritoneum dissection, and you can find that internal iliac artery and all that. So pelvic devascularization is done. Third is if placenta is there, you know that if she's already having a placenta eccrita, before only the screening everything is positive, then don't separate the placenta. Just separate the placenta with the myometrium and stitch the myometrial defect. Okay, that is the third P. You can do that. Okay. So how to open the abdomen? You open with vertical midline incision because it is easy to find out better visualization. And if you want to do that internal iliac artery ligation, then also it is easy. Then before giving incision, inspect the uterus. How big is the uterus? Any vessels, any vascularity? You already know the placenta where it is located by means of marking. So you just imagine in your brain. Third, third is you can estimate the position of placenta. Then you accordingly you give the incision. Fourth, uh, after delivering of the fetus, keep the placenta in situ and do cesarean hysterectomy. Some people follow that I want uterus, then you can go for partial myometric resection. Okay, like it depends upon the depth and surface area. And if the small part of placenta is only adhered, then it is very easy for resecting that myometrium and repairing that. For these patients, you should monitor volume status, urine output, blood loss, hemodynamics should be monitored. And these patients should be educated that, see, if you're having any blood loss or your bleeding is not controlled, then there is a high risk of peripartum secondary complication and also risk of secondary hysterectomy. We will call again her and do hysterectomy if the bleeding is not controlled. There is one Indian evidence known as PAC, that is Paley aorta clamp. Okay, this clamp over the peritoneum, we can clamp the abdominal aorta. So bleeding can be controlled. This can be used. Then placenta percreta, this is also the same thing. Here the it is entering into the myometrium. So just deliver the fetus, don't disturb the placenta, and do hysterectomy. Some people say that you can leave the placenta inside and do elective cesarean hysterectomy, secondary hysterectomy, sorry, in 3 to 7 days. Okay, you can do that. If you want to leave the placenta inside, there is no need of, you should have a regular review of that patient. Methotrexate adjuvant therapy is not recommended in expected management. Okay. Then if the percutator is there, um, if the if your if a patient antenatally came with placenta percata, mother and baby both are safe, then you can delay the cesarean section until the staff and good staff is there. Okay, that's it. Post-operatively, you should debrief her what happened in the surgery. You should give thromboprophylaxis and you should be vigilant on ongoing bleeding. So conclusion of this topic is you should take good history, ultrasound screening proper clinically, and the bank should be present, NICU facility present should be present. You should operate when there is good obstetrician, skilled obstetrician, sonologist, interventional radiologist, neonatologist should be present. All backup facilities should be present. A tertiary care center only should do that. And primary prevention of preventing this pass is decreasing the number of cesarean sections. Okay. I felt on revision, I felt this pack is important, periaortic clamp, and this triple P procedure very important Viva question. Okay, perioperative for localization of the placental edge, pelvic devascularization. Third point is placental non-separation with myometrial resection and repair of myometrial defect. Okay, this is that's it. Thank you.